Good morning. Donna, middle name Schwartz, Schwartz, last name Maddox, Maddox.
Good morning, Dr. Max.
Good morning.
Can you tell the ladies and gentlemen of the jury a little bit about yourself, who you are, what your work history is, your educational experience?
Sure. I'm originally, raised in Columbia for 50 years. I went to Lower Richland High School. I went to college at Furman University, and I graduated in 1985 with a Bachelor of Arts degree in psychology. Then I went to medical school at the University of South Carolina, School of Medicine here in Columbia, next door in Columbia, and I graduated from there in 1989. Then I did a 4-year residency in general psychiatry, and I finished that. At that time, it was run by the Department of Mental Health and the University of South Carolina, so I finished that program in 4 years. Then I took an additional year of training in forensic psychiatry, which is a 1-year fellowship, and I finished that in 1994. I'm licensed to practice medicine in South Carolina and Georgia. After I finished residency, I worked for a number of years at the Department of Mental Health. And while I was there, I conducted court-ordered evaluations similar to Dr. Frierson's, looking at people's competency to stand trial and criminal responsibility. Then I went over to USC and worked at the medical school for 17 years. And there I basically did forensic work. I worked in the prison. I worked at the Department of Juvenile Justice, just various areas. And I also performed evaluations similar to what I've done today. And then after that, I finally retired. I spent the last 8 years of my career working at the Department of Mental Health, and I was an inpatient psychiatrist there. So for 4 years, I worked at Bryan Psychiatric Hospital, and that's a hospital in Columbia, the acute hospital when people are civilly committed from the emergency room. They go into treatment there. So I worked there, and then I remarried and moved to Anderson, South Carolina 6 years ago. And I worked for 4 years at Patrick Harris Hospital, which is the sister hospital to Bryan. So Patrick Harris Hospital is the acute psychiatric inpatient unit for the upstate. And there I was a psychiatric service chief, and I ran a 40-bed unit of females who were acutely mentally ill. So I retired from the state. I had my 28 years of service. So I retired from the state 2 years ago, and since then I've been engaged in the full-time practice of private forensic psychiatry.
Have you been qualified as an expert in forensic psychiatry in the state of South Carolina?
I have.
Do you know about how many times?
Over 800.
Have you been retained by both the state and the defense in different, not the same case, but in different cases over your years of service in South Carolina?
I have.
At this time, the defense would offer Dr. Maddox as an expert in forensic psychiatry.
Dr. Maddox is offered as an expert in the field of forensic psychiatry. She can offer opinions to that end.
Dr. Maddox, can you tell the jury a little bit about the difference between treating patients, clinically seeing patients, versus evaluating?
Yes. In forensic psychiatry, the focus is a little different. In forensics, because there's a legal issue involved, you're evaluating someone, number one, to determine a diagnosis. That's important because you can't advise the court or lawyers in legal decisions if you don't understand what's going on with the patient. And then you have very specific focuses that you're looking for. You're answering legal questions. And when you treat, so let me back up. So when you're a forensic psychiatrist, you are advocating for an opinion. Forensic psychiatrists are not on anybody's side. They're looking for a diagnosis and trying to answer a legal question. When you treat patients, you're their advocate. So if you're an inpatient in the psychiatric hospital and you're my patient, I'm going to do everything I can to help you. I'm going to prescribe medications. I'm going to make sure that you're safe, that you're not a danger to anybody, and we'll help you with discharge. So when you treat patients, you see them in a different context. You're with them for a longer period of time. So for example, at Patrick Harris, the average length of stay of a patient was usually 2 weeks. And so every day I would round on that patient. You would have inpatient evaluations. You would read the nurse's notes every day. So you get a little bit, you know your patient in a different way. You observe them more frequently because you're on the unit, so you have more interactions with them. So the focus is different. One is for treatment and to help and to cure, And forensics is just to render an opinion that will hopefully assist a jury or judge in making a decision.
And can you tell ladies and jury what your role was in the Tim Jones case?
Yes. Mr. Young called me, I believe, the day after Mr. Jones was sent to the Department of Corrections. And he called me, and I came down, I believe it was a Saturday, actually. I was a day off, but I drove to Columbia at that time from Anderson, and I evaluated Mr. Jones at the Kirkland prison where he was being housed. And so it was my opinion at that time he was clearly psychotic. There was no question in my mind. You know, the cause we didn't know yet, but there was no question that he was psychotic. And what happened over the course of time, I was involved in a very big case. I would not have had the time to be the forensic expert in this case because that takes a lot of work and a lot of hours. And so Mr. Young used me as a consultant over the last few years. So since 2014, I saw Mr. Jones on September 13th, 2014. So I have seen him almost every year. I didn't see him in 2018. But I would go by once a year, check on him, see his progress. I was keeping up with his treatment, what kinds of treatments he was receiving. So I've been a consultant in this case where I've come a few times since the trial started and have done some evaluations. So my role has not been to render an opinion about whether he was criminally responsible, as you saw in the first phase. But my job has been to just be a consultant, order tests when needed, oversee treatment, those sorts of things.
Over the course of time, in that role, have you come to a diagnosis of Mr. Jones?
I have.
And can you tell the ladies and gentlemen what that is and how to improve it?
Yes. Mr. Jones meets the diagnostic criteria for schizophrenia. And I base that on my evaluations of him from 2014 until the present. And I do agree, we certainly know that he was using synthetic cannabis, and that can cause psychosis in somebody. And that certainly may have contributed to what I saw on September 13th, 2014. But what the issue is usually people that have substance-induced psychosis, I've treated them, I spent the last 7, 8 years doing that. They usually clear up within a month. You can bring them into the hospital, you give them medications, they clear up, and then they're no longer psychotic. You can eventually take them off their medications, and they're fine. If they use these kind of substances again, they will get sick again. But in this case, I have followed him since 2014. In my opinion, he continues to have symptoms of psychosis. And so based on that, the diagnostic criteria for schizophrenia says that you had to have had symptoms for 6 months. Well, we know he's been confined since September of 2014. This is 5 years later, 4.5 years later. He still has symptoms of psychosis. So he would diagnostically, he's had the criteria for more than 6 months. In my opinion, he's had delusions in the past. The last time I saw him, I did not consider him delusional. He had delusions about his son. He's continued to report hallucinations off and on. Even despite being on medications the entire time that he's been confined, he still has those symptoms. And then mainly, the main thing you see in schizophrenia, which differentiates it from a substance-induced psychosis, is you see a deterioration in function. That's one of the hallmarks of schizophrenia. It's someone that was doing well, then they got sick, and their function has continued to decrease. So he went from being a father, a full-time worker, wanting to go to school at some point or go to medical school, to the point where he's murdered his children. He's been confined. He had a suicide attempt. So his function continues to deteriorate. In my opinion, he's also had what's called cognitive decline. Cognition is just it's about 6 things that your brain does: paying attention to things, your ability to concentrate, your ability to make decisions, those sort of things. He's had a decline in that as well over a period of time. And in the old days, we recognized that. And they used to call schizophrenia dementia precox. Before they really knew what schizophrenia was, they realized that there's some cognitive dysfunction that you have with that illness as you continue to have it over time. So based on those things, he's had delusions, hallucinations, a deterioration in function, and he also has what's called negative symptoms of schizophrenia. There's 2 kinds of symptoms you see in schizophrenia. Positive means your brain's doing something it's not supposed to do. It's making up things, it's making you believe things that aren't true, or it's making hallucinations. Negative symptoms is your brain stops doing some of the things that it normally does. And the main negative symptom he has is what's called a flat affect. If I took a picture of his emotions, you see me, I'm talking, I use my hands, my voice has a lot of intonation. If I'm happy, you would be able to tell. persons with schizophrenia, their outside expression of emotion flattens out. And so you don't see him very animated. There's times that he may be, but overall, he's not a very emotionally expressive person now, and that's called a negative symptom of schizophrenia. So since September 13th, when I saw him in 2014, he was psychotic. 2015, he had gotten a little bit better. He was on medications, but he still was having symptoms. 2016, he was still much better. He was getting medications, but he had tried to kill himself and had a little bit of much more negative symptoms in. So initially what I saw is the positive symptoms early on, and then as he remained treated on all of his medications, he's developing more negative symptoms now, which is consistent with that illness.
Does schizophrenia always present the same? I mean, you say, like, all right, it's schizophrenia, it's always exactly like this?
No, it's just like every other medical illness. There's always going to be outliers, or there's always going to be somebody that's not textbook. That we see that all the time. In fact, I've got a case right now, the person got the symptoms in their 40s, and that's usually very late for the onset of schizophrenia, but it happens. I had patients in the hospital. I had one woman, she had retired from a job and got schizophrenia in her late 40s. So there's not, all illnesses in medicine work that way. Not everybody's a textbook case. And so that's the question. How do you piece together that this is schizophrenia and not just from substance? And I think one of the most important things that I also considered in that is the family history. You know, we know that his mother was institutionalized, and I tried to look up the most recent research. If you look at our DSM, which is a book that lets us diagnose schizophrenia, they report that if you have a parent with schizophrenia, you may have about a 1 in 10 chance. Well, the more recent articles that I looked up says you have a 1 in 3 chance as a child of a schizophrenic. You have a 1 in 3 chance of getting a major mental illness. You have a 1 in 2 chance of just having a mental illness. And so based on his family history, that's a strong genetic component. He did do the drugs, which I think contributed to him having the symptoms. But you have to take it at the point of 2014 on. He still has those symptoms, and he clearly meets the diagnostic criteria for schizophrenia.
Now, and I think you talked about your evaluation of him on September the 13th, 2014. That was the day after he was admitted to Kirk.
Yes.
And then you saw him in June 24th, 2015. This was prior to his suicide attempt.
Yes.
And how was he doing at that point?
At that point, he was only on one medication for psychosis. He was on the Geodon. They had him on Prozac, an antidepressant. They had him on a medicine called Inderal, and that's medicine for side effects. You can get tremors from some of the medicines, or you can have problems where you can't sit still. That medicine helps. He was on Geodon, which is an antipsychotic. He was on a medicine for nightmares. He was on another antidepressant for sleep, and then a medicine for his stomach. He reported at that time he looked much better than when I saw him in 2014. It was night and day. There was improvement in him, but he was still having some symptoms. He said he felt like his thinking had cleared up. He said it had been a while since he had had any hallucinations, and he was definitely in a much better place. He was having a lot of issues about his crime, thinking back about his children and what he had done.
What did he say about the lack of auditory hallucinations?
He said he felt like part of him was gone because he no longer heard them. He said, I got along with them for years. The main symptom, so he didn't have positive symptoms of schizophrenia at that point, but he had the flat affect. That's the first time I noticed that he definitely was getting some of the negative symptoms that you see with schizophrenia.
Is that an odd thing for somebody to say if they're trying to fake mental illness?
No, and it's not. I have a lot of people with schizophrenia that say that. Most of the times in schizophrenia, the voices, they don't say nice things. They're just horrible. They say awful things. When you're trying to concentrate on a task, it's when you're nervous is when the symptoms will come a lot of times. So say if you're in a crowded room and you're scared, that's when the voices will come. And they usually say not nice things to people. And that's because it's coming from your own brain. You know, your brain is what's making those hallucinations, so they know just what to say to usually harm you. They're very good at that. Sometimes people are lucky, and some of them will have voices that say, maybe tell them jokes. In my hospital, it wouldn't be uncommon. You might see a lady in the corner just laughing because she's responded to hallucinations. Sometimes they're pleasant. but mostly they're not. And they make running commentaries about what you're doing. They may say things like you're ugly, you're a bad person, that person hates you, look at everybody looking at you. They don't say very good things.
Did you think that that was indication that he was malingering, or was it indication that he was not?
To me, it's an indication he wasn't malingering. What happens is people are so used to living with those voices, they learn how to cope with them. They might have strategies. And so when they're gone, it's kind of like getting a free day off. You didn't plan on it, so you don't know what to do. You have to fill the time. Or I think a better example would be somebody that's in chronic pain. When their pain's relieved, they've spent so much time trying to learn how to deal with the pain that it's kind of like they're at a loss for a little period of time. So that's certainly, I have a lot of patients on the inpatient unit that have said they feel like part of them is they're different and they have to readjust.
The next time you saw Tim was on April 18th of 2016. This was after his suicide attempt. What did you notice about him at that point?
Well, at that point, he was on 2 antipsychotic medications, and you could tell. He definitely was having side effects from the medications. The first thing I noticed is he had what's called Parkinsonian features. His facial muscles were not moving. These medications can cause side effects that look like Parkinson's, and so he wasn't blinking his eyes very much. And so he looked, even though last time I'd seen him, I called him a flat, he didn't have a lot of emotional expression. Well, it was even worse with him being on the medication. So he didn't have a lot of movements of his muscles and those sorts of things. He was on a much stronger medication. He was still on the Geodon, but Dr. Wood added Prolixin, which is one of the older. Those are old drugs since the 80s that we used to use. There's a lot newer medicines now, but it's still a very good medication. So she had added a second antipsychotic medication. So I saw that he was having a lot of side effects from his medications. He stated the voices were gone, but he told me that he had hallucinated and the voices were telling him to hang himself, which was how his suicide attempt came about.
Did you notice a change in his cognitive level?
Yes.
That evaluation?
Yes. One of the things I do when I do an exam, I try to assess cognition, and there's different tests that psychiatrists use. But you're looking. One of the tests that I did on him when I would see him, it's called a test of verbal fluency, and you'll probably practice this at home tonight. I practice all these tests on my husband, but it's a frontal lobe function. It's a part of your brain that you're trying to measure, like how quickly are people thinking, how rapid are they able to come up with placing objects in categories. And so the test I usually I'll give you a minute, and I'll say, name every word you can think of that starts with the letter D. And then you have the person. If you get 11, then you pass. Sometimes I might make it a category test. I'll say, name every fruit you can think of in the next minute. So the first time I saw Mr. Jones, he scored, and I try to do that. I try to assess cognition as I go along. The first time I did the test, he got 23 words in a minute. That's one of the highest scores I have ever seen. He did one thing that was interesting, though. He had what's called perseveration. And what that means is his brain came up with the same word twice. And sometimes people's brain will do that on its own, but usually it can mean that there's a dysfunction there. So the example would be if you're given words that start with the letter D, they may say the word dog twice. I'll say, did I say that? It's like their brain's going back to the same pattern. It's trying to come up with information using the same strategy. So you can see perseveration in people with dementia or people with certain kinds of brain trauma. So he did 23, so he scored excellently. I saw him, the evaluation in April, he got 6. So he went from doing superior performance on that test to below average when I gave it to him in April.
And did you order some neuropsych testing as a result?
Yes, and I did. I recommended neuropsych testing at that point because that was a decline in function, and I didn't know what was causing it. Sometimes schizophrenia can do that. Again, they used to call it dementia precox because it attacks the chemical system of your brain, but it still affects how your brain functions. And then I had also, the first time I had evaluated him, I did not see, he had hair when I saw him, so I did not appreciate the skull depression that he had. His hair covered that up. But I had learned from speaking with one of the Department of Corrections that he had had the automobile accident. So because of those two things, the decrease in his function and the history of the head injury, I recommended that you all get neuropsychological testing.
And is that the Dr. Brawley testing that you've ordered?
Yes.
After that testing, did you then order imaging?
Yes. He had some abnormalities on his neuropsych testing. Some of them were probably secondary to medication side effects. Some of them, he was having motor symptoms. So part of the neuropsych testing is you have to look at motor function. But the functioning that I was concerned of was the frontal lobe issues. And so, yes, Dr. Brawley recommended further workup, and at that point I ordered the MRI of his head.
I'm going to skip forward a little bit to the time of the trial. Did you get a call about May 8th this year to come in and see Mr. Jones? What was the call about, and what did you see and what happened?
Yes, I did. I think this was during jury selection. I don't know if you all had started yet. You may have already been in trial. He had been reporting some hallucinations, and that was kind of new for him. So what had happened, I'll fast forward a little bit, but put it into context. When he was at the Department of Corrections, he was held as a safekeeper. And so Dr. Beverly Wood, whom I know I've worked with, I used to work at the Department of Corrections. I was one of her contract psychiatrists when I was here in Columbia. He had been on a very high dose, probably the highest dose of Geodon I've ever seen. I think he was on 320 milligrams at one time. I've used 240 before, but I'm not that brave. But he was on very high doses of Geodon in the prison. And what happened is by the time he had got back here to Lexington, he was only on 40 milligrams. So his dose had gone from very, very high dose to a very low dose. And so some of his symptoms were returning, which could be expected. If you have somebody with schizophrenia and their symptoms are controlled and they come under a lot of stress, it's just like any other medical illness. If you have hypertension and you're not sleeping well and you're getting up really early every day, and even though you're taking your medicines, you may have symptoms. And so it's just like any other illness. So at that point, I recommended that his medication be increased to 60 milligrams a day to prevent any further hallucinations for him.
And then did you get another call on May the 22nd?
I did.
Trial?
I did.
And who called you on the 22nd?
Officer Sowards called me, Barry Sowards, at 7 o'clock in the morning.
And what did he tell you, and what did you do in response to that?
He was concerned. He reported that the night before, when Mr. Jones had come back from the trial, that when he dropped him off at the jail that night, that they put him on suicide watch. He reported that Mr. Jones had not been sleeping and that he was very concerned about his mental state, that he wasn't the same, that he was more withdrawn, more quiet, and he had noticed some symptoms. So I came down here and evaluated him, and he was having some symptoms. So I wanted to increase his medications again to a dose of 80 milligrams. So what started at that point is I called Dr. Woods at the Department of Corrections to figure out, there was some concern about why his medication had been decreased and did he need it. And she told me directly that what had happened when he was at where he was being held at Lee County in Kirkland to get his medicines, with Geodon, you have to have 320 calories with that medicine, or else it's not as effective. So what they did in the Department of Corrections, they would give it to him with a teaspoon of peanut butter, and he would take his medication at night. And what happened at Lee County, he was not getting his medications regularly, and there were nights when they were not giving him a snack. And so he asked her to begin tapering the medication because he wasn't able to take it as prescribed. And she reported that she saw a slow decline in his functioning with him not being on that medication. The other problem that happened is the Prolixin that he was on, which is a very good medication. She had to change that to another medicine. What happened in the United States, there was a shortage of Prolixin. So normally that's a very cheap drug. It's about 5 cents a pill. When it went up, it was exorbitant in cost. And so the Department of Corrections couldn't afford that medication. Plus, there was even a shortage at our hospital. We had to take all the patients off of Prolixin for a period of time. And so she had started him on another antipsychotic called perfenazine, which it's an older one, but it's very effective as well. So what happened is I asked to increase his medications to 80 milligrams. I got a call from the jail that night from the jail nurse. I had spoke with them earlier as well, and they complied with that. I had to write a prescription because their psychiatric nurse practitioner was on vacation that week. So I wrote a prescription, and they called, and my understanding was they raised his dose.
I think you've already talked about this a little bit, but can you explain to the jury a little bit further about your consideration of whether or not this was drug-induced psychosis and how you arrived at the conclusion that, or what was your conclusion regarding?
Sure. Drugs definitely played a part in it, as it does with many mental illness. If you look, one of our areas of training is called dual diagnosis. It is not uncommon at all. Many of our people with major mental illness are using drugs. Some are self-medicating, some are just abusing drugs. That's very common in the mentally ill population. So I think the synthetic marijuana definitely contributed to forming his symptoms, but he meets the criteria for schizophrenia. The criteria says for 6 months you have to have these symptoms. He's had them for 5 years without any drugs and being medicated. So in my opinion, even though the substances certainly contributed, which it does in many times, you can have somebody that's got a genetic predisposition to schizophrenia, and they develop the symptoms when they're using marijuana, or they'll develop the symptoms under the guise of a drug. So it contributes, but it doesn't cause it.
Did you consider the possibility that he was faking or malignant?
Yes.
And what did you conclude with regard to that?
He underreports. If anything, he underreports symptoms. For example, the hallucinations that he would generally report, he would say they were just vague. Well, the reason they're vague is they say little things like get up now, move now. They're not anything contextually that, they're not telling him to go shoot the president. If you heard a voice like that, you would remember something like that. But they comment on things that he's doing, so the content of them is not something that's memorable. So if you ask him last week, what did they say? If he didn't write them down, he's not going to remember the content of them. He's never, I saw him on the first visit. You can't malinger. He was so labile. He had a lot of emotion at that point, screaming, crying, cursing. It was clear that he was responding to things. What I see lasting now that I don't think he's faking, so for example, if you ask him what your illness is, he can tell you all the symptoms, delusions, hallucinations, but just like every other schizophrenic patient I have, he lacks insight. He can't tell when he's having the symptoms. So, for example, last week when I saw him the other week, he was very paranoid. I've not seen him like that since probably his first visit. And when I went in to see him about his mental state, he's like, who told you I was up all night singing Twinkle, Twinkle, Little Star? Well, nobody told me that. Nobody told me that. He goes, I wasn't doing that. So when he's having his own symptoms, he can't recognize them, even though he can tell you what the symptoms are. And that's the way most patients are with schizophrenia. They know something's wrong with them, but when they're having the symptoms, they're not able to identify those things. And so in my opinion, I've not seen him intentionally feign symptoms. I've seen him underreport and not tell everything that's going on with them. So I think what he's more consistent with is not being forthcoming with all the symptoms that he's having.
Does the South Carolina Department of Corrections medicate people just to pacify the population?
Oh, no. They've done studies, epidemiological studies in the Department of Corrections. 33% of women usually have mental illness in Department of Corrections. 17% of males have mental illness in the Department of Corrections, generally across the United States. In South Carolina, when we worked at the Department of Corrections, they were only identifying about 8 to 10% of the males. So we were missing half the males that were mentally ill. And one of the reasons that happened is they're usually quiet. A lot of people with schizophrenia are not out there raising Cain. They're quietly in their cells. They don't go outside. So they don't always come to attention of the mental health professionals unless you ask the question specifically or something happens. So they're underrepresented, first of all, in South Carolina Department of Corrections. I gave that lecture when I went there to the Department of Corrections to talk about those things when Osment was the director. But what happens is, so most of them are not getting attention, and there's so many people that are in need of mental health treatment. It is certainly was not my practice to treat people that didn't need it. When they came in, these clients were usually quite sick, and they were in need of psychiatric treatment. You do have some. Every hospital has them. Every prison has them. You have a group of people that are drug seeking, but people don't drug seek for Geodon or perfenazine. Those are not the kinds of drugs you would want to be on. They sedate you. They make your muscles feel heavy. They put you at risk for a permanent movement disorder called tardive dyskinesia. These are not the drugs that have any street value. You can't. There's one antipsychotic called Seroquel you can sell in the prison and make $10 a pill because it helps people sleep. But all these other ones, they don't have those effects, and they are not a drug that you would see prescribed for a drug seeker.
During this time, the defense would offer for court's exhibit a copy of Dr. Maddox's report.
Your Honor, we object. She's testified, reports don't go in.
We've done that with all the experts. The reason the reports don't come in is she's right here. And she can testify to everything she knows and be cross-examined. The report can't be cross-examined. She's here. So.
If I misspoke, I was offering it as a court's exhibit.
Oh, okay. Yeah, I'll accept it as court.
And I don't have any problem with that.
Yeah, okay.
If I misspoke, I apologize.
Okay, you did, but we've gone through that same scenario each time with the CV and with reports. It's all
Yes.
perfect. So we're on the same page. I may have misunderstood.
Thanks. Please answer any questions.
Certainly.
Doctor, good to see you again.
You too.
Now, you were hired in this case basically pretty much like you were in, what case was that, 2014? Ricky Lee Blackwell, Spartanburg death penalty case with Mr. Young.
I'm going
and
to check
Mr.
to
McGuire.
bring up Mr. Blackwell.
No, that was a little bit different.
How she got hired? No.
It was different in the Ricky Blackwell case. It was a sentencing issue, and actually, you are correct in the sense I was treating him. I believe I was prescribing Mr. Blackwell's medications. I might be wrong, Mr. Hubbard, but I think I was actually doing some of the prescribing. But I did, yes, I was hired early on to oversee his treatment, and then I think I got called in the sentencing phase. So it is similar, but I think I actually treated Mr. Blackwell.
You got called in the sentencing phase, all for a diagnosis.
Of depression, that's right.
So it's very similar.
Yes, it actually it is, yeah.
You say your first meeting was just the day after the defendant gets to the Department of Corrections. It's September 13th.
Yes, sir.
And you've reached a diagnosis of schizophrenia, continuous type, and an unspecified neurocognitive disorder.
Yes.
Correct? Now, you've had the opportunity to review the reports of all the various experts, both by the defense and the court appointed.
I think I've reviewed most of them, yes. I put the ones in that I used in the report, but yes, I'm aware of kind of what both sides have been saying.
And although you make your own opinion, you definitely would consider what these other folks have said, their observations, because they're professionals as well.
Sure.
And I think you would agree that sometimes experts disagree.
Sure. Even doctors disagree, not only just experts, but in medicine, sometimes you'll get second opinions. That's right.
So you mentioned Dr. Tora Brawley. You've done a lot of work with her in the past.
Yes.
Including on a number of death penalty cases.
Yes.
Where you've called her in to look at somebody because you think there's some neurocognitive deficit, so you want her to run tests. And you did that in this case.
That's correct. It depends. Sometimes I'll be allowed, if I recommend neuropsych testing, I can recommend somebody, but sometimes it's the lawyers will have someone else in mind. So if there's no one else, I would recommend her because I know that I trust her methodology.
Trust her methodology. She was brought in on this case at your recommendation.
Yes.
She did testing that was back in, what was it, April 19th of 2016.
I think so. I've got her report. I'll be glad to look at that.
Only testing you asked her to do was neurocognitive testing.
Yeah, that's what she does, neuropsychological testing. Neuropsychological testing, You can have an MRI that shows the structure of your brain, but it doesn't tell you what the brain is doing. So it's the gold standard. If you want to see how someone's brain is functioning, you order neuropsychological testing. So that's what she did her fellowship in. That's her specialty.
Sure, and it has since come to light that while she was doing that testing, the defendant was on 320 milligrams of Geodon, which
Yes.
I think you made a comment that you're not brave enough to prescribe that much to anyone, but Dr. Wood was.
Yes.
And you're aware that the defendant himself, when he later saw Dr. Cruz for the same type of testing, said, I couldn't think straight because of all the Geodon.
Yes, I'm aware he said that.
And he was so smart, so alert, he was able to tell the actual dosage, the dosage per pound, and a breakdown, almost like a doctor talking about Geodon.
I would not be surprised. I wasn't aware that he knew all the breakdowns. With me, some of the times he didn't know the doses. He always knew his medication, but there were some times where he may not have known the exact doses. But some of the times when I saw him, his medications were being titrated.
And Dr. Brawley concluded with that testing that he had a low IQ, it's about 89, 87, somewhere in that range. And he scored the first percentile on a whole host of tests testing various parts of his brain. Correct?
Yes, that's fair.
And that's the lowest you go. I mean, anything lower, you're pretty much dead. Agreed?
No.
1 percentile is as low as you go.
It's as low as you can go, but believe it or not, even with 1 percentile, a lot of demented patients may show up, and they can do some rudimentary things. But yes, that's as low as you can go. If you line 100 people up, you would be at the back of the line.
Then in February of this year, when Dr. Cruz tested him and gave him a similar array of tests, he was in 70, 80, and even 90 percentile. A huge difference, correct?
Sure.
I noticed in your report, you say that you considered and relied on Dr. Brawley.
Absolutely.
That her testing is what you relied on. You didn't even mention, even when you, well, let me specify. The first report we got from you, you went and you updated it, because the first one we got was in March of 19 this year, and you've done an update from last month, May 29th.
That's correct, because I saw him the 2 times, and I felt that would be unfair to you not to memorialize what my findings were, so I updated it so you all would have my most current observations.
And in updating it, you had Dr. Cruz's information, and you discounted it because that's nowhere. It did not affect your opinion on his cognitive issues at all. You made no change.
That's correct.
You went with Dr. Brawley over Cruz as far as the assessment.
No, not at all. That's not how it works. To diagnose, first of all, there's 3 different kinds of cognitive disorders you can diagnose if you look in our book. One is called a major neurocognitive disorder, and that means you think somebody has dementia. That means it's very serious. They have impairments for whatever the cause. There's about 8 different causes of dementia. But when you diagnose a major neurocognitive deficit, you think that they have dementia. There's also a diagnosis called minor neurocognitive impairment, which means they have some impairments, usually in one global area of cognitive function, sometimes more than one, but for dementia you have to have 4. I made the lowest diagnosis there is, and unspecified means that I know that there's something wrong with his cognition, but I'm not saying that it's at the level that it's a dementia or a severe impairment, that I'm just recognizing that there's been some cognitive impairment. You can have that level of cognitive impairment from schizophrenia. He could have that level of cognitive impairment from an abnormal, from a head injury. But what happened in the DSM-5, they want us to base it. Psychiatrists, you have to have a test or some kind of basis for that. I could have based it on the MRI. But at that time, it doesn't matter that he scored better when Dr. Cruz saw him. It mattered that he had the cognitive deficit when he was tested by Dr. Brawley. And so that diagnosis, it doesn't matter. If he's schizophrenic and he's on 320 milligrams of Geodon, he's got a cognitive deficit.
But doctor, that brings in the whole issue of it's hard to diagnose schizophrenia when somebody's high on drugs. And that would be the issue you'd be dealing with that same test. If he's on 320 milligrams of Geodon, which is supposed to help with schizophrenia, how in the world do you get a schizophrenia diagnosis when somebody is that high? How do you know that the effects you're seeing aren't from the drugs?
That's a great question, and that really is. That's the question. What I did, I'm lucky because I've had the 5 years since. And so I base my diagnosis on the fact that he, even on medicine, we know he's not using the drugs anymore, and 5 years later, in my opinion, he still meets the criteria. He still has symptoms.
Correct. But the last and most recent cognitive test was this year, and he did great.
Sure.
Even if he had schizophrenia, he did great,
Sure.
right?
Sure.
And that's not in your report.
He still meets the criteria for a neurocognitive disorder. Whether he did well or not, he still has impairments. And I don't know what it's from. It could have been the head injury. It could be drugs. It could be the medication side effects. All I'm saying is there's something there. I don't know the cause. There's too many questions about it.
In schizophrenia, you diagnosed, you made a diagnosis of that. Now, schizophrenia, you'd agree with me, is one of the most debilitating mental illnesses we know.
It can be, yes. For people with schizophrenia, we call it the rule of threes. 30% get better, 30% stay the same, and 30% have a continuing deteriorating course, even with medication.
They get better without medication?
No, you must have medications for this illness.
That's the point.
Yes.
It's a debilitating disease. If it's not treated, it just gets worse and worse.
Absolutely, and even some people that do get medication, they get worse too.
People with schizophrenia have commonly experienced social and functional deficits such as less social contact, difficulty obtaining and maintaining employment, challenges to independent living that significantly impact their quality of life. Correct?
Yes.
Now, up until really the day of this murder, or these murders, he was working at Intel, had just gotten a promotion 4 months before,
Yes.
was living, maintaining his life, sending his kids to school, dressing his kids, doing all the things that he's supposed to do, and going to work at a very high stress,
Yes.
really challenging job. He was doing that.
Yes.
And you mentioned that in diagnosing him, he's kind of an atypical patient if he in fact has schizophrenia, because most of them get it in their late teens, early 20s to mid-20s, right?
Yes.
So he would be atypical if in fact he has this disease.
Yes, in my opinion, he reported in his history he had some hallucinations, but I considered that to be his first psychotic break. That's correct. And I believe he would have been in his 30s, which is much older than what you would normally see.
Usually when there is an onset of psychosis, it's preceded by a month or even years of prior disturbances.
Yes, it's called a prodrome. Sometimes, and it's just like any other illness. Before your hypertension gets diagnosed, you might not be feeling well for a few weeks. Something doesn't feel right. You can tell something's wrong with you, and it's not until somebody measures your blood pressure and you realize what your symptom is. So that's right. Normally there's a prodrome. You can see a slow deterioration in function. Some people it's really fast, and some people it's insidious.
So there should be a very visible history of a slow breakdown with this man over a period of time, both at his job, his relations, and just how he lived on a daily basis, absent drugs.
Correct.
And you think you see that with Mr. Johns?
Well, my diagnosis is based on my observations from 2014 through now, but yes, I would beg to differ. He was getting in trouble with DSS. He lost his marriage, so he had a deterioration in his personal relationships, and he was getting into some legal situations with his children, which had not, as far as I know, had not been his history. So I would say that there was some decline.
Breakdown with his marriage. While he was married, that was actually the most stable period of his life. Was it 9 years, no drugs, no alcohol, no arrests?
That's correct. And I don't think DSS had been called during that period of time while they were together.
Actually, that's when it was
Right.
DSS was involved. It was because how he controlled that family and
Right.
how he ran that house.
Correct.
But he was continuing to do well at work, make money,
Yes.
get promotions.
Yes.
He was high functioning.
Yes.
It didn't affect his daily life.
Not his daily function in terms of vocation and earning a living and finances. That's correct.
Now, again, we go back to a number of experts have looked at the same information, the same case, and experts differ.
Sure.
Obviously, you know Dr. Frierson. You've known him for many years.
Yes, and respect him greatly. We were colleagues at USC for a number of years. He was a year ahead of me in medical school, so we've known each other since 1985.
He's exceptionally well thought of.
Oh, absolutely. Certainly by me.
And we've heard from Dr. Dorney out of Georgia.
Yeah, I don't know her.
I didn't either. And then, of course, Dr. Wood.
Yes.
CDC.
And I hold her in very high esteem as well.
None of them came up with the assessment of schizophrenia. Frierson obviously said it's not there. Dr. Dorney had schizoaffective. And then Dr. Wood, she changed her diagnosis multiple times. One time schizoaffective, and maybe it's just a undiagnosed psychosis. But she was all over the place. But you would agree, experts can disagree.
Yes, but I would like to, if I can answer that. Schizoaffective disorder and schizophrenia, if you read the DSM, you can change that diagnosis. I've done that. I had a certain patient of mine, there was a period of time, she was very manic. I added a mood stabilizer to her antipsychotic, and then she remained psychotic. So you actually, the DSM, you can see that diagnosis change. So what happens is, if you think somebody has schizoaffective disorder, which is schizophrenia plus a mood disorder, if you treat the mood disorder and they remain psychotic for a period of, it's predominantly psychosis, you can change the diagnosis back. So changing that is not necessarily meaning that people's opinions differ. It means the patient's changed over time, their clinical symptoms. So I think what's more important is the fact that I think every one of the experts has agreed he's been psychotic. I think people are just not, they're attributing different causes for psychosis.
To the extent it was Dr. Frierson, there was no organic psychotic disorder that he found. It was simply when he chose to take drugs and got high. Correct?
I wouldn't argue. I think he diagnosed as synthetic cannabis-induced psychosis.
And then as far as what his job was, he didn't say he was psychotic that night. You're aware of that. He was paranoid. It didn't reach the level of psychosis.
Okay, I would not disagree. I trust you and would not disagree with that.
Now, schizoaffective, typically to get to that, you have to rule out schizophrenia as being a sole, independent, standalone mental health issue, right?
Right.
So,
but I can show you in the DSM, they're interchangeable. You can, clinically, you can change them. So say, for example, when I saw Mr. Jones, he was much more psychotic than him having any mental disorder. When I first saw him, I didn't pick up any depression in him. He was psychotic. So when I saw him the following year and he was on an antidepressant, I was a little surprised. But of course, I had not seen him in a year. So your presentations, you can get comorbid illnesses with schizophrenia. And so that's not, it's just the course of the illness. People have different outcomes or different prognoses.
both you and Dr. Frierson would agree that schizoaffective just wasn't in this case, right?
I have not seen that. That's right. Each of the data points, I've got 1, 2, 3, 4, 5, 6 data points with him since 2014. I have not in any of those evaluations appreciated a significant mood component. Now, also keep in mind he's been on antidepressants, so maybe had he not been on those, I would see more, but I have not appreciated mood symptoms in him.
He had no sustained euphoric or manic episodes.
No, in my opinion, not.
No significant symptoms of depression outside of his separation divorce.
He's had a few symptoms, but not enough to meet the criteria for a major mood disorder, in my opinion.
And he would often describe his mood, I guess, as I'm happy one minute, I'm sad the next. That's clearly not bipolar.
No, in my opinion, I did not diagnose him with bipolar disorder.
But it would all show a trait, and you would agree with this, wouldn't you, of borderline. Sure,
It could. Borderline personality disorder. Personality disorders are different from mental illness. Some of them, they don't usually have genetic components. It's the way that you adapt to the world, and usually you have to have things that go on in your childhood and your upbringing. So people with borderline personality disorders, I didn't diagnose them with that, but they'll have rapid shifts in their mood. in their mood based on things. Maybe you're really happy, and all of a sudden you start thinking badly about yourself, and your mood decreases. So it's not uncommon for them to have mood shifts all during the day. You can also get a psychosis with that kind of personality disorder if they're under enough stress. But certainly you could call someone with frequent suicidal ideation, intense unstable relationships, reckless behavior, and frequent mood shifts. They would meet the criteria for borderline personality.
Borderline would include also things like frantic efforts to avoid real or imagined abandonment.
Oh, absolutely. Those are people that if you break up with them, they might stalk you. They're trying to get you back. They can resort to all kinds of behaviors to maintain a relationship.
Chronic feelings of emptiness or no one loves me.
The emptiness, I think, is emptiness. I don't think it's no one loves me. It's just they don't feel anything. They're empty.
I'm unlovable.
They can believe that at times, sure.
Which is, of course, going back to Frierson and Cruz, they both found elements of that or traits of that.
I wouldn't argue with that. Certainly, that personality trait is most common in people that have been abused or have been exposed to abuse. You get that disorder from witnessing trauma or being a victim of trauma. And my understanding that he had some traumatic experiences at childhood. So that would certainly be consistent with his history.
Let's talk a little bit about his history, because there was never a point in time in his history where DSS or some form of social services had to enter his house and threaten his dad, his parents, or his grandmother. They were going to take him and remove him from the home.
That's correct.
Although there's law enforcement out there on multiple occasions, no one ever said this child's in danger.
Correct.
There was never a time when he, as a child, went to school and the school said, oh my gosh, this child's not eating.
That's correct.
He's being underfed.
Not that I'm aware of.
He never got to school with, say, a piece of bread and some grapes.
Not that I'm aware of.
He was being taken care of. There was never a time when anybody ever made an allegation that he was being physically abused.
Not that I'm aware of.
In fact, he absolutely adamantly denies any physical abuse growing up.
He certainly minimized, I think, some of his traumas, but that's correct.
Never came to school with bruises on his arms, his face, his neck, where the school said, oh my gosh, we got to look into this.
Not that I'm aware of. I didn't see any reports indicating that.
Safe to say we would know by now, wouldn't we?
Sure. Sure.
So it's not there.
Well, it's not reported or it's not right. I can't answer that.
And regardless of what kind of life he had growing up, his father always tried to be there, go to his events, do all those things that dads are supposed to do. He showed up for big events.
I don't have that specific knowledge because I've just kind of been overseeing his treatment, but I wouldn't disagree with you if you say it. I'm sure it's been presented.
He didn't fail to show up for like sports events or say a graduation.
I'm going to take your word for it, but
now, you never ordered or asked for any type of testing from a psychologist, a neuropsychologist, to see if he had any form of psychosis or personality disorder.
I didn't need one. I've been doing this for 29 years. I'm pretty good at picking with psychotic patients, making the diagnosis. You would use that testing in someone if you weren't sure of their diagnosis, but I didn't feel that was indicated. I certainly would have if I needed it.
Carson did.
Yes, and that's different. He was doing the forensic evaluation. Had I been doing an evaluation for that purpose, I may have. But when you're clinically overseeing someone or following them along, his diagnosis was clear to me. I didn't need extra tests to help me figure that out.
Doing a forensic evaluation, first you have to basically do what you would say is a clinical evaluation. You have to see if he has a psychosis.
That's correct.
So that was step one, and that testing dealt with step one.
Yes, but I saw him psychotic. On September 2014, there was no question. I was absolutely certain with my observations, clinical training, and experience, there was no question in my mind he was psychotic. The issue was what was the cause.
And having had available Dr. Cruz's scientific, objective data, saying that there was no psychosis, but signs of malingering as to the testing specifically for psychosis. You discounted that because you felt comfortable with your opinion.
I discounted that because it was 5 years later. I saw him closer to the crime than anybody else. I saw him at that point. I have no doubt if she says he's malingering, perhaps he was malingering, but that's 5 years later. When I saw him, he was not malingering.
But doctor, if he had schizophrenia when you saw him in 2014, then he has schizophrenia now.
Yes, in my opinion, he does.
So what does 5 years later matter?
5 years later, he doesn't have acute positive symptoms. He's got hallucinations. He doesn't have the delusions anymore. He's got the negative symptoms you see in schizophrenia and the hallucinations, but he's on medication. He's been medicated now for 5 years, so there's a big difference.
What's his delusion?
The delusion involved his son.
And that's gone now because the son's gone.
He still had it the third visit. He still believed that his son was meaning him harm.
His son was doing what?
The son had blown out the electrical outlets to perhaps harm him in retaliation for them divorcing.
Did you not listen to a phone call he had with his dad, his aunt, it was November of 2014, where he doesn't mention any of that. He says the entire event was because Matan was a catalyst. Matan wanted to go back to his mom. He lost it. Basically, between the lines, he killed his son for that reason. And it was Amber's fault, not his son's fault. You can put this one on Amber. If she had been here instead of next door bopping the boy next door, this wouldn't have happened. You're aware of that phone call?
Yes. But that's still, in my opinion, that's still months later after medication. At the time I saw him, I think he had gotten 1 dose of medication. And so I had that data point before anyone else saw him and before he had been medicated. And he was very clear at that time. He was very focused on his son's behavior and was very focused on the electrical sockets being burned out and believed that this child somehow was responsible for wiring the house to try to kill him, which is absolutely not true. So I consider that a delusion.
While he was at SCDC and he was complaining of hallucinations, Toshiro and Abinant, one
Yes.
of those folks that I think you've said you looked at what Toshiro and Abinant had to say.
Yes, he was his case manager as soon as he went into Supermax, and so I met with, the day that I met Mr. Jones, I consulted with Mr. Inabnet.
Part of his job was to keep his eyes on Mr. Jones to see how he was acting.
Absolutely, yes.
And he said although he complained of hearing voices, he was never observed to be responding to internal stimuli as if he was hallucinating. He was never disorganized in his thinking or behavior.
I agree with both of those. I've not seen him actively hallucinating, and no, I agree with both of those. And his even when he was psychotic acutely, his affect was very labile, but he was generally able to stay on task.
Dr. Wood basically said she accepted he was psychotic because he kept talking about he was hallucinating, but he never displayed disorganized thinking or behavior while he was at SCDC in her care.
I wouldn't disagree with that. That would be consistent with my observations as well.
Basically, you had an opportunity to observe him, and a lot of what you've based your opinion on are your observations with him.
Yes.
Also based on his self-reporting, what he's telling you,
Certainly.
and that he's hearing voices or seeing things, and then you address that when he says that.
Yes, I assess it.
May 8th, 2019, when you saw him, he was going through jury selection, as you said, right?
Yes.
So you had to up his Geodon. He was getting nervous.
Yes.
May 22nd of this year, just happened to be the day, I believe, Well, right at the time, we'd had Dave Mackey from the FBI testify, Amber Kaiser testified, I think we had Mike Phipps.
Yes, that was a very emotional day in court, yes.
And he wasn't suicidal, but he was demanding more Geodon.
That's correct.
And they put him in basically what he called a skirt, a robe,
A turtle suit.
turtle suit. And he was all upset because men don't wear dresses and skirts, men wear pants. So he showed out.
That's fair to say. He certainly, I think he stayed naked. He refused to wear the turtle suit.
He asserted control.
I call it a preoccupation with religion and some of his, that I had not seen before. I actually considered that a symptom of his illness. In all the other interviews I had with him, I've never had him at that level. And he was very religiously preoccupied, talking about what clothes people are supposed to wear, and that wearing a turtle suit was against his religious belief. And I don't know any religious belief that would be consistent with that. I consider that a religious preoccupation that I have not seen in him in any of the other times I interviewed him. That's what it concerned me, because that was a change in his thinking.
When you first saw him in September 2014, that was 7 days after daily spy shoots.
Yes,
You said he was psychotic.
yes.
And then as to that jail call from November of 2014, based on what you're saying, that delusion about his son was still going on.
All I can tell you is the data points I have, and he still had it later when I saw him. Now, certainly your call would make you wonder whether he was being accurate in reporting it or not, and I can't say that.
And that gets us down to, I guess, this point. He has lied about so many things at different times. You would not consider him for a minute to be an accurate historian.
No, not at all. And it depends on the context. Certainly, there's people that have criminal charges. That's one of the things we're trained for. You know, they may fabricate symptoms to get out of punishments, or they may fabricate symptoms to be able to get financial rewards or things like that. Part of my whole private practice as an outpatient doctor at USC is I took care of workers' comp patients. And, you know, so a lot of times there was malingering there because they were out of work and needed money. So, yeah, no, you have to take those things into account.
As far as delusions, he's not having delusions anymore, is he?
No, not. He certainly was paranoid the other week when I saw him, which also caused me to increase the medicine. Again, who said I was up all night singing "Twinkle, Twinkle, Little Star," and he was upset about that. So he had some paranoia, but I don't think it was a delusion. I agree with you.
Reporting "Twinkle, Twinkle, Little Star" is not diagnostic of schizophrenia. That's just, I'm scared.
No, that's a paranoid ideation.
Paranoia.
Yes.
Even Dr. Frierson said he suffers from a level of paranoia. Most of it was drug-induced. He's wanting more drugs, Geodon at that time.
Geodon is not a drug you ask for. It has no street value. It does not get you high. Geodon decreases your dopamine, which makes you not hallucinate. It is not any kind of medication that would have any street value at all.
It calms you down.
Right. It calms schizophrenics down.
And it's been used for other types of,
Psychosis.
and anger issues, things like that.
I don't do that, but I've seen other clinicians. There's clinicians if people are having, say, post-traumatic stress disorder and they have paranoid ideation from that, but it's in much lower doses. But yeah, you can use it for, I don't use it for behavior, I use it for symptoms, but it can happen.
Bottom line, as far as delusions is concerned, he's not having them, you would say it's because he's being properly medicated and tended to.
Yes, and he's not doing drugs, and he's not using synthetic marijuana. Both of those things matter.
But it's also true that the delusion that he complained about, that his little boy was conniving, going to hurt him, trying to get back to mom, that little boy's gone. So
Absolutely.
There's no one to be delusional about.
Yes and no. Sometimes it doesn't work. I've certainly seen cases where the person's dead, but the patient can continue to have delusions. He doesn't. So I would say it's because he's medicated and he's not using drugs.
Well, killed his son and his other children. He was just taking care of the matter himself.
I'm sorry.
He was just taking care of the matter himself.
He certainly took it into his own hands.
Just going back, I see your report. I missed this. This goes to him being the reliable historian. He mentioned that Eli had threatened to cut his mother up and feed her to the dog.
Yes,
Did you realize he ended up saying later he made that up?
I would not be surprised. Can you tell me what date that was?
It's in your report.
Yes,
It's on page 2 of your report.
2. Thank you.
Thank you, Dr. Maddox.
You are very welcome.
Dr. Maddox, have you ever been hired by Mr. Hubbard's office?
I have.
Have you been hired by Mr. Hubbard's office in the case of Clinton Northside?
Yes, but Mr. Donnie Myers was a solicitor then. I believe he was. I think it was Mr. Myers and Dayton Riddle who hired me on that case.
That was definitely a case here in Lifetime.
It was.
And that was the case that you were retained and worked for the state in that case.
Yes.
Thank you, Dr. Myers. That's all I have.
No more
Thank you.
questions?
All right, we'll do for a break. Dr. Matt, sit down, get in the jury room, don't talk about the case.